Alhamdulillahi Rabbil Alameen. Hello to all my colleagues, my fans, and my students everywhere. This is Professor Dr. Tarek Ali. Today I will speak about signs and symptoms in clinical medicine or clinical signs and symptoms in medical practice. I had a talk before, or maybe more than one talk, about symptoms and signs and their significance in clinical diagnosis and management, and for diagnosis of disease. And this is basic in clinical medicine. But today I want to, as a continuation of these lectures or these presentations in my YouTube TV channel before, and some were presented in my Facebook account, maybe a few years before. But today I will highlight some clinically significant symptoms and signs which the clinician should be aware of, whether in practice and also for medical students in clinical examinations. Let us start by stressing on the point that science in medicine or science in clinical practice is one of three things. There are science in pathology, what we call pathological science, which may be of diagnostic importance for important pathology, whether on gross examination, that is macroscopically on gross examination of an organ for a pathology in this organ. For example, for in the liver, liver tumor, or for hydatid cyst in the liver, or for gamma of the liver, which is one of the syphilitic manifestations, tertiary syphilis manifestations in the liver, gamma. Or pathology in the kidney, the horseshoe kidney, or whatever the other organs. Just giving examples. So these signs may be of pathological significance on gross pathology. Also on microscopy, that is in histopathology. In histopathology, there is definite signs which might be of pathological significance in diagnosis in different diseases, and these are countless. And they can be of importance for the histopathologist and for the anatomical pathologists to diagnose disease on histopathology, that is microscopic examination of tissue specimen. So the signs, these are called pathological signs, whether on histopathology or on gross pathology, that is gross examination of the organ for a definite pathology inside it, whether an infective pathology or neoplastic pathology or an autoimmune pathology or even other types of pathology, like in autoimmune diseases and in traumatic pathology and in infective pathology with all its spectrum: bacterial, viral, fungal, parasitic, protozoal, etc. This is called the pathological signs. And we have also, number two, radiological signs, which are signs detected on radiologic examination. And these are also, we have many examples. They are countless. They can't be counted. They are unlimited. In the field of diagnostic radiology, like, for example, the bat swing appearance. I will give just examples. The bat swing appearance of the chest X-ray in patients with cardiogenic pulmonary edema. We call it the bat swing appearance or the bat swing sign. Also the bird peak sign in patients with achalasia. This is another radiological signs. And also the in patients with hydatid pulmonary hydatid disease, the little sign in patients with hydatid disease in the lung, pulmonary hydatid disease. And Also in patients with gliomas of the brain, in patients with hydrocephalus, in patients with countless examples. We have signs which are seen on radiology, and they help the diagnostic radiologist in diagnosis of the specific disease when he or she see this sign on radiology. Also, it can be picked up by a clinician when he has the radiograph of the patient, whether it is a plain radiograph or a CT scan or MRI. There are countless radiological signs which are of medical importance and help in clinical diagnosis. And the medical student and the clinician should be aware of most, I will not say all, but at least most of these signs which are seen on radiology. We call it radiological signs of disease. Now, let me shift to the third group, which are the clinical signs of disease, and these are signs which are seen on bedside examination or on physical examination of the patient by the clinician. On physical examination, that when the clinician shifts from the step of history taking to get to pick up the symptoms, then to the physical examination to detect any physical signs. Among these important physical signs which are common and which are of pathological significance, we have, for example, in patients with there are countless signs or countless number of physical signs in patients with acute appendicitis. For example, there is what we call the famous McBurney sign, which is tenderness in the right iliac fossa. We have the Rovsing sign, which is what we call tenderness that in the right iliac fossa on palpation of the left iliac fossa, and this Rovsing sign. We have the shifting tenderness in pregnancy, shifting tenderness in pregnancy with acute appendicitis. And this also is another important or clinically significant physical sign in pregnancy with acute appendicitis, in pregnancy with acute appendicitis. And this is what we call the Alder sign. Also, we have the Aron sign, also in acute appendicitis, and this is epigastric tenderness or epigastric distress in patients with acute appendicitis, and this is, we call it the Aron's sign. So we have Aron's sign, it is acute appendicitis with epigastric tenderness and distress, that is some sort of discomfort in the epigastrium in patients with acute appendicitis, and this is called the Aron's sign. And we have Alder sign, I mentioned it, is shifting tenderness if a pregnant lady has acute appendicitis. We call it the Alder sign. And we have the usual signs of acute appendicitis, which are McBurney sign, at the tenderness at the McBurney point in the right iliac fossa, and the Rovsing sign, which is tenderness in the right iliac fossa on palpation of the left iliac fossa. That is, when the clinician press on the left iliac, there is tenderness in the right iliac fossa. And this is called the Rovsing sign. So as we see, there are multiple signs, physical signs in patients with appendicitis. Also in patients with acute hemorrhagic pancreatitis, we might have also, in addition to these signs which I mentioned, we might have what we call Cope sign and psoas signs also in patients with acute appendicitis, depending on the site of the appendix. If the appendix is pelvic appendix, it will irritate the psoas muscle, and we can elicit the psoas sign in patients with acute appendicitis, and we call it the psoas sign. Also, we have the Cope sign also in patients with acute appendicitis. So the Rovsing sign, the McBurney sign, the Alder sign, the Aron sign, the psoas sign, the Cope sign, these are signs, physical signs, which can be elicited in patients with acute appendicitis. In patients with acute hemorrhagic pancreatitis, we might also have other physical signs on abdominal examination, and these are the Cullen sign or Cullen sign, which is bruises around the umbilicus, and the Gray-Turner sign, which is bruising in the lumbar area. So, or the lumbar region on inspection will find the bruising in the lumbar region, and it's called the Gray Turner sign. And the Cullen sign, it is bruises around the umbilicus also in patients with acute hemorrhagic pancreatitis. And we have a Fox sign, which is bruise near the inguinal ligament or above the inguinal ligament, also in acute hemorrhagic pancreatitis. So we have Fox sign, which is bruising above the inguinal ligament, commonly on the left side, but it can happen on the right also, but commonly on the left side. McBurney, the Cullen sign, it is bruising around the umbilicus in acute hemorrhagic pancreatitis, the Cullen sign. And the Gray Turner sign, which is hemorrhagic skin or bruises in the skin in the lumbar region in acute hemorrhagic pancreatitis, and the Fox sign, which is bruising above the inguinal ligament, also in acute hemorrhagic pancreatitis. So we have at least 3 physical signs in patients with acute hemorrhagic pancreatitis, which can be seen on physical examination, precisely on abdominal examination in patients with acute hemorrhagic pancreatitis. So this is very important. Also, we have in patients with congenital pyloric stenosis, a mass which is olive-like mass in the epigastrium in patients with pyloric stenosis, namely congenital or hereditary pyloric stenosis, the olive-shaped mass in the epigastrium. This is also an important physical sign in pyloric stenosis. In patients with intussusception, we might have what we call the Hamilton belly sign on abdominal examination. It will give what we call sausage-shaped mass in one of the iliac fossas. In this sausage-shaped mass in patients with intussusception, which is a surgical emergency, of course, and one of the causes of acute abdomen, and this is called the Hamilton belly sign. So this is also another sign on abdominal examination. So I mentioned here many signs on abdominal examination. In other physical signs which can be distinctive and indicate specific medical diagnosis, and it can indicate the diagnosis precisely, is, for example, what we call the Gower sign in patients with Duchenne muscular dystrophy, the Gower sign in Duchenne muscular dystrophy. Also the descending muscular weakness and descending muscular paralysis in patients with myasthenia gravis. The ascending muscle weakness in patients with Guillain-Barré syndrome, which is a neurological condition. Also the famous Cushing's triad in intracranial hypertension, which is hypertension, that is hypertension with bradycardia and bradypnea. So that's why we call it hyperbrady triad. So there is 3 clinical signs, which is called the Cushing's triad. It is different from Cushing reflex, which is an endocrine condition of hypercortisolism due to excess cortisol secretion. We'll talk about it by the adrenal or by the pituitary adenoma. So the Cushing's triad, it is a constellation of 3 signs. It's not a single physical sign, it is 3 physical signs. It is hypertension, bradycardia, and the bradypnea in patients with intracranial hypertension. We call this the Cushing's triad, or the Cushing's reflex, due to elevation of intracranial pressure by brain edema, by intracranial tumor, by whatever etiology. In patients with brain trauma, in patients with supratentorial or infratentorial space-occupying lesions of the brain, or brainstem tumors, or brainstem lesions, or inflammations, or this is called the Cushing's triad, or the Cushing reflex. It is a combination of hypertension and bradycardia and bradypnea due to stimulation of the vital centers in the medulla oblongata of the brain by the medullary edema and inflammation in patients with, as I mentioned, as examples, pathologies like a tumor or like inflammation of the substance of the brainstem, namely the medulla oblongata, and this will cause the Cushing's triad. Also, we have the triad of hypotension with tachycardia and the tachypnea in patients with shock, and this is the opposite. We call it hypotachy. So the Cushing triad is hyper-brady, but this one in shock states, in shock in general, whether septic shock, cardiogenic shock, hypovolemic shock, or anaphylactic or neurogenic shock, any type of shock, we have the combination of the three, which is hypotension, not hypertension as in the Cushing's triad or the Cushing's fixed intracranial hypertension. Here, in shock states, we get this triad of hypotension with tachycardia and tachypnea in most of the cases of shock. But we might get brady in shock syndrome, that is bradycardia, if the condition causing the shock, to be more precise, cardiogenic shock with bradycardia, and this might happen. But the classic shock state is associated with hypotension, tachycardia, and tachypnea, not bradycardia. Tachycardia and tachypnea, that is increased respiratory rate and increased cardiac rate or heart rate, and hypotension. This is the classic triad of shock state in general, but we have exceptions, or some exceptions in some shock conditions which might not be associated with the classic triad. Also, the lethal triad of life-threatening or end-of-life shock state, which is hypotension, coagulopathy, and hypothermia. We call it the lethal triad in the advanced shock, which has gone into the irreversible stage, and this means that the patient is approaching death or is having impending death. So this advanced form of a non-treated shock state, we call it the lethal triad. So these are physical signs also in shock. In patients with hepatitis, we have the classic icteric sclera or yellow sclera, jaundice, especially if associated with enlarged tender liver. So enlarged tender liver with yellow sclera is diagnostic of hepatitis. Also, dyspnea associated with tachycardia and gallop, whether S3 gallop or S4 gallop or S3 S4 gallop, and with arrhythmias and conduction abnormalities in the ECG, this plus or minus fever, this might be diagnostic of carditis. So carditis, we get tachycardia, gallop, and fever. So fever, tachycardia, and gallop are diagnostic of carditis. In patients, so this also, these physical signs are diagnostic of this condition, which is carditis. In patients with meningitis, we might get headache, photophobia, this classic triad, headache, photophobia, plus signs of meningeal irritation. The three famous signs of meningeal irritation, as we all know, is Brudzinski's neck sign, and the Kernick sign. So these three clinical signs, we call it signs of meningeal irritation, plus photophobia, that is fear of light, and headache, and of course fever, in spite of the fact that sometimes fever is absent or unnoticed or very low grade, especially if the patient is taking antipyretics like paracetamol. But this triad of headache, meningeal irritation, and photophobia diagnosed of meningitis. So I mentioned examples of inflammations, three common inflammatory conditions in three common organs with their characteristic physical signs. So which are the hepatitis, as I mentioned, the icteric sclera, carditis, the tachycardia and the gallop, meningitis, the signs of meningeal irritation with headache and as a symptom, and photophobia. Photophobia is seen as a physical sign. When you lighten the room, or that's why the patient with meningitis like to stay in a dark room. So this is another signs. In patients with ophthalmopathy, Graves' disease, we have Graves' ophthalmopathy, In addition to the exophthalmos, which is characteristic physical sign, we might get also other physical signs of Graves ophthalmopathy, like the Graves sign, and this Graves sign, it is an lag of the lower lid on upward gaze. لما تقول لعيان بص لفوق اللي عنده exophthalmos due to Graves disease, which is Graves thyroiditis, one of the causes of primary hyperthyroidism. We get this Graves sign, what we call the Graves sign, also we might have the Dalrymple sign. Dalrymple sign, which is retraction of the upper eyelid in patients with Graves ophthalmopathy. We call it Dalrymple sign. So the Dalrymple sign, the proptosis, these are characteristic of Graves disease. And we have also some other physical signs you might be associated also with Graves ophthalmopathy. Also, in patients with DVT, we have another important, this is thrombophlebitis of the lower limb veins, which is a common medical condition, the DVT, or thrombophlebitis. We have Homan sign, which is tenderness in the calf when we dorsiflex the foot. We get tender, swollen calf with tenderness in the calf on dorsiflexion of the foot in patient with thrombophlebitis, this Homan sign. So don't forget Homan sign in DVT. Also, it's a characteristic physical sign which help in diagnosis of DVT. In Cushing's disease, we have characteristic moon-like faces, which is very diagnostic, plethoric red face due to secondary erythrocytosis, and facial edema, together with of course, the buffalo neck, and the buffalo neck together with the classic enlargement and hypertrophy of the the increased fat beds above the deltoid muscles and on the back of the patient and the back of the neck, the classic buffalo neck. So we can diagnose Cushing's disease or Cushing syndrome from the facial look. Of course, the facial or the faces is very important in medical diagnosis. Sometimes you can diagnose the condition by looking at the face of the patient, like the face of the plethoric moon-like faces or the rounded red face of Cushing's syndrome or Cushing's disease. Like the faces of patients with acromegaly, you will find the coarse facial features with prognathism and with prominent superciliary ridges and with the prominent lower jaw with widened interdental spaces and prominent superciliary ridges and of course thick nose and broad thick lips of the patient. So the coarse, collectively we call it the coarse facial features, of acromegalic patient. Also, the faces of myxedema, it is commonly a rounded face, edematous face, with puffiness of the lower eyelids and puffiness around the eyes, and lazy face and face which is like lassitude, like face or facial features in patients with myxedema, which is an extreme form of hypothyroidism. Untreated hypothyroidism for a long time, will cause what we call myxedema, with myxedematous tissue deposition in different parts of the body, in the legs, in the hands, in the feet, in the face, causing the classic myxedematous faces, classically with edema around the eyes and puffy eyelids. So the myxedematous faces in myxedema patients. Also in Addison's disease, we have the classic hypotension and the classic pigmentation of the skin. So the bronzed color skin in patients with Addison's disease, which is adrenal hypofunction, which is adrenal cortical hypofunction. So the discoloration, bronzed color skin, hypotension, these to physical features on physical examination will allow in or will help us in physical diagnosis. So look at the skin, look at the mucous membranes to diagnose in patients with hypotension, which might in some cases be persistent hypotension or postural hypotension. Sometimes the blood pressure is okay when the patient is sitting, but when getting it stand up from the chair or from the bed, he gets postural hypotension. But in the classic Addison's disease, we have persistent hypotension, especially in moderately severe and severe cases. We have hypotension with bronze color skin or changes in the color of the skin of the hands, especially, and of the mucous membrane when you examine the mucous membrane of the mouth in patients with Addison's disease. Before you proceed, of course, to the laboratory to detect the hyponatremia, the hyperkalemia, the increased blood urea nitrogen, the low blood sugar, which are all classic laboratory signs or features of Addison's disease. So I mentioned here the physical signs in patients with some endocrine diseases. Also, the physical signs which are characteristic of some clinical syndromes, especially those observed in the skull and in the face, that is especially in patients with craniodysostosis and premature fusion of the bones of the face and the skull, in patients with some clinical syndromes like patients with trisomy 21 or trisomy 18, which is Edwards syndrome, or Pathognomonic syndrome, trisomy 13, or other also clinical syndromes like hereditary clinical syndromes like the genetic obesity syndromes, the Lawrence-Moon-Beadle, also the classic physical signs in patients with some other syndromes like the neurocutaneous syndromes, or what we call phacomatosis, especially in the patients with tuberous sclerosis and patients with what we call the cavernous retinal angiomas with brain angiomas in other patients with the other classic syndromes, which we describe them collectively as neurocutaneous syndromes because they affect the neurological system or the nervous system and the skin, the most common of which is, of course, neurofibromatosis. The neurofibromatosis with its type 1 and type 2, and type 2A and type 2B. And also, in addition to neurofibromatosis, the second most common is tuberous sclerosis with ash leaf spots and other skin lesions characteristic of this type of syndrome. So the facial features, the skull, the shape of the skull, the abnormalities in the morphology of the musculoskeletal system, musculoskeletal abnormalities, especially affecting the skull and the faces in patients with some genetic syndromes, might help in physical diagnosis also of the condition. As I mentioned, the shape of the hands, the shape of the face, the look of the face, the shape of the skull, all these physical signs can, if we detect them, if we pick them up, can help us in diagnosis of hereditary clinical syndromes. So I here described many physical signs. Also in patients with emphysema, we have the barrel-shaped chest. Also in the, as I mentioned, the in patients with pericardial effusion, we might get dullness on percussion of the lower angle of the left scapula. We have the PEX triad of cardiac tamponade, which is increased jugular venous pressure with bradycardia and hypotension. This triad, it is a triad of that is three physical signs. We call it PEX triad in cardiac tamponade. So I mentioned here many examples of many physical signs. Of course, we have a Murphy sign in patients with acute cholecystitis. I mentioned it before. The Murphy sign, also on abdominal examination, we can detect it. A Murphy sign is positive in acute cholecystitis. And we have the Courvoisier sign or Courvoisier law, which Courvoisier sign, which help us in patients with cholestatic jaundice. When we feel the gallbladder, it's not, so we can say that it's not due to a gallstone disease. So when we find that there is enlarged gallbladder in patient with cholestatic jaundice, this is called the Courvoisier law or Courvoisier sign, which we need to elicit it in patients with obstructive jaundice or cholestatic jaundice, the deep colored jaundice of the sclera, especially if associated with also deep yellow color discoloration of the skin in patients with cholestatic jaundice, whether due to calcular causes or due to carcinoma head of the pancreas, malignancy and affecting the head of the pancreas. So to know whether this is due to stones or not, to the Courvoisier sign or Courvoisier. The Courvoisier law is what, as I mentioned, that is the palpation of the gallbladder in patients with obstructive jaundice means that it's not due to gallstones. So this is the law. We call this Courvoisier law. And the sign which we elicited, and we need to do it in patients with cholestatic jaundice, is Courvoisier sign. So I mentioned in relation to the biliary tract, the Murphy sign in cholecystitis and the Courvoisier sign in cholestatic jaundice. So this is collectively or just a quick revision of important physical signs which help us in clinical diagnosis, in clinical practice. And of course, there are many other physical signs, both common and rare, which help us in clinical diagnosis, but it's a book or a textbook. I will not give a textbook in half an hour, so I'm just giving you examples of some clinically important physical signs which are peculiar or distinctive clinical features indicating an underlying pathology and pointing to a specific diagnosis or a specific medical condition or diagnosis. That's why we call it pathognomonic physical signs or pathognomonic physical signs. And we can elicit them while we do physical examination. On physical examination of the abdomen to detect the underlying medical diagnosis inside the abdomen, in appendicitis, in hemorrhagic pancreatitis, in intussusception, in bacterial stenosis, in hepatitis, etc. And of course, we have a ballotment with floating kidney, another sign. Signs of splenic rupture also, they are important, but I will not say it to you now. Just go and revise by yourself to know the physical signs of rupture of the spleen. Also some of physical signs of other serious conditions in the abdomen, like peritonitis, like retroperitoneal hemorrhage, etc. And also on physical examination of the chest, physical examination of the heart to detect carditis, chest to detect pneumonias. In pneumonias, we have important sign, but this sign is, and sometimes the clinical signs is not on physical examination. Sometimes the clinical sign is not detected on physical examination. As I mentioned, in the color of the skin, cyanosis, so this is a cyanotic condition due to respiratory failure. So we have to or congenital cyanotic heart disease. We have to look what is the, and here the colors in clinical medicines as important physical signs, the colors. If the color of the skin is blue and the mucous membranes also is cyanosis. If it is yellow, this is jaundice. Look for an underlying cause of jaundice, whether it is hemolytic jaundice, hepatocellular jaundice, or hepatic jaundice, or number 3, the obstructive or cholestatic jaundice, the 3 types of jaundice. When it is pale, look for anemia and differential diagnosis of other causes of pallor. But the most common is anemia, which is a deficiency of hemoglobin. It is a hematological condition, so look for a blood disease. But of course, there are other conditions which cause pallor, like vasoconstriction of the skin, especially if it is localized to the hands or fingers in patients with Raynaud's disease, or the pallor may be general in the general appearance or in the general look of the patient, and here this might indicate anemia, and we have to look for underlying cause of anemia. So pallor, this is pale skin. Yellow, this is jaundice. Blue, this is cyanosis. So colors of the skin important other physical signs or important clinical signs, but not in the physique, not in the body, it is in the examination of secretions of the body. For example, the sputum, you have to look for the color of the sputum to see the rusty sputum in patients with pneumonia. So the greenish rusty sputum is pathognomonic of pneumonia, that is inflammation of the lung tissue, the parenchyma of the lung. So in classic pneumonia, especially bacterial pneumonias, there is rusty sputum. It is a bloody or dark bloody sputum that is due to degraded hemoglobin inside the sputum. But the classic greenish yellow, it is a diagnostic of bacterial pneumonias like Pseudomonas, like Klebsiella, like streptococcal pneumonia, that is pneumococcal pneumonia. We get the classic greenish yellow. But the rusty is diagnosed, is pathognomonic of pneumonias in general. At some stage of the disease, because it means a degraded hemoglobin in the sputum. Or maybe the oncoviscosus sputum in amoebic lung abscess. This is classic in medical history. Oncoviscosus, the sputum of, when the amoebic lung abscess rupture into the bronchi and the contents of the amoebic abscess go outside, it will appear as what we call oncoviscosus. زي كده الايه صلصة الانكوفي, as described by the British medical literature, oncoviscosus sputum of amoebic lung abscess, or the classic sputum of ruptured hydatid cyst of the lung. Also, when the small hydatids, they are released into the sputum of the patient due to rupture of a big hydatid cyst in the lung. This also in the sputum. So sputum examination is very important, in fact, to look at the sputum by the naked eye. In addition, of course, to examination of the sputum to look for eosinophils in eosinophilic lung syndromes, allergic lung diseases. So examination of sputum is very important. Examination of the urine to see hematuria in patients with microscopic hematuria and macroscopic hematuria, gross hematuria, if it is painless due to hypernephroma, which is lung cancer, which is renal cancer, hypernephroma, which is a malignant tumor of the kidney, it causes painless hematuria. Or painful hematuria in patients with stones, the UT stones, or urolithiasis, that is calcular urinary disease. You get hematuria, or foreign body in the urinary tract, or tumors in the urinary tract, we get hematuria. Bloody urine. Or might get also other colors of urine, like the orange colored urine due to drugs, like the black urine due to alkaptonuria, which is a hereditary condition, metabolic condition causing black colored urine. The tea-colored urine of obstructive jaundice, also the dark urine of intermittent porphyria. So changes in the urine color might point to specific medical diagnosis. So don't forget to examine the urine color. So color of the urine is important. Color of the stools is important. The classic sign of rice water stools in cholera. In cholera, the cholera causes change in the character, in the color of stool, which and makes it like mayat al-roz, or we call it rice water diarrhea. So the rice water diarrhea of cholera, it is important, and it appears in the color of the stools or the color of the feces. The bloody stools, especially if intermittent bloody diarrhea, characteristic of ulcerative colitis in patients with inflammatory bowel disease. So bloody in inflammatory bowel disease, especially ulcerative colitis. The rice water stools of cholera, which is infection by Vibrio cholera. It is dangerous infection which might be life-threatening and killing. Cholera, rice water stools. Also the bloody stools of ulcerative colitis. As I mentioned also, sometimes parasites appear in the stools, so we have to examine the stools to look for the character and the nature of stools and the color of stools, which might help in diagnosis, as I mentioned. Examination of the skin also to look for some physical signs like the vesicles of chickenpox, like the complex spots of measles, like the rose spots of typhoid and salmonella infections give some vesicular, some characteristic skin rash. As I mentioned, vesicular in chickenpox, which is a pustular skin condition or vesicular skin condition, chickenpox due to varicella zoster virus. Or also maybe in shingles, we find that there is a vesicular eruption in the skin, on the face, on the upper chest, on the back, around the ear, in Ramsay-Hunt syndrome. So here, sometimes the characteristic physical sign is in the skin and gives a characteristic rash. Also, the pulse rash sign, which is the erythema migrans in patients with Lyme's disease, which is caused by Borrelia burgdorferi. And Lyme's disease, there is characteristic rash. We call it the erythema migrans chronicum, or the classic bull's rash, and we call it the bull's rash sign, characteristic of Lyme disease. So the bull's rash, characteristic of Lyme's disease. We have also other types of rashes, which are like the target skin rash, characteristic of erythema multiforme and the Stevens-Johnson syndrome, and the characteristic rashes of scalded skin syndrome, which is staphylococcal skin condition. The characteristic rash of psoriasis, for example, helps in diagnosis, which is plaques and scaly conditions of the skin, characteristic of psoriasis. So examination of the skin might pick also I mentioned complex spots on the skin in measles, which is a viral condition, measles اللي هي الحصبة. Also in patient the red rose spots or the rose spots, characteristic of typhoid in patients presenting with or suffering from typhoid, which is a Salmonella typhi infection. So don't forget physical signs in the skin also. They are of utmost clinical importance and they help in clinical diagnosis. So that's why, in order to pick up these physical signs, focus on the skin, focus on the mucous membrane, focus on the eyes. And there is important sign in, of course, the eyes. The eye by itself carry many important physical signs, countless, like the conjunctivitis in patients with Reiter syndrome, which is one of a rheumatological condition, triad characteristic by conjunctivitis, urethritis, and arthritis. Arthritis joints, urethritis, that is urethra, urinary tract, conjunctivitis, and uveitis. So this triad is called the Reiter's triad, characteristic of Reiter syndrome. The three important physical signs help in diagnosis of Reiter's disease, which is one of the causes of seronegative spondyloarthropathies, a group of rheumatological conditions, Reiter syndrome. And of course, the iridocyclitis of Behçet syndrome, which is characterized basically by orogenital ulcers on the genital mucosa in males and females, on the genital on genital organs, on ulcers in the mouth, mucous membrane of the mouth. This is called orogenital ulcers, together with iridocyclitis, and in some cases some other manifestations in other organs, especially in the joints. We might get arthropathy, because we know the basal pathology in Behçet's disease is a form of vasculitis affecting the veins and the venules and the capillaries, especially at the anatomical level. So this is also a very important medical condition. The conjunctivitis, iridocyclitis, opacification in cataract, the halo vision or peripheral visual loss in glaucoma, the hemorrhagic conditions of the sclera and the conjunctiva can be helpful in hemorrhagic fevers, or can be seen in hemorrhagic fevers and in dengue and in yellow fever. So also what we call the cat's eye sign in patients with retinoblastoma, which is a malignant tumor of the retina, can be seen as what we call the cat's eye sign, and we can pick it on examination of the pupil of the patient on eye examination. So abnormalities may appear in the pupil, in the cornea, in the conjunctiva, in the sclera, in the lens, in the red reflex, in the pupillary reflexes, and also on fundus examination in the retina. retina. So examination of the eye especially and of the skin especially might carry many important clinically significant physical signs, in addition to local examination of the abdomen, of the chest, of the heart, of the nervous system, as I mentioned, in Duchenne dystrophy, in myasthenia gravis, in multiple sclerosis, in Landry-Guillain-Barré syndrome. So there are characteristic physical signs which are of clinical significance. Thank you so much, Professor Dr. Tarek Ali.